We then realized that it may not be a good idea and not possible to go to different places and do the programs every time. So we started with the e-learning, starting off with the free YouTube videos. And there are over 400 videos which are available freely in that perspective. And these videos basically are accessible to across the globe. And a lot of people have been accessing these videos over this time. And as we are looking at currently, there are a lot of people who are subscribing even to this program as well. So there are over 1.5 million views which have been given in these videos in terms of this e-learning program. We then realized that we needed to have a structured program rather than just having some videos. So we started off first with a fellowship program from 2017. And till date in the Regency Center of Diabetes Endocrinology and Research, we have had 11 fellows who have been involved. And I remember Dr. Kapoor, when we went for the first time, and he said that, yes, we should start the program. It was one of the few centers which started the program at that point of time. So in the last 7 years, continuously, we have got very good fellows and with good support from the hospital. In 2018, we started the online learning portal MedEClasses, and then a lot of books and application came up. So we have got pediatric endocrine learning tools. We have got fellowship programs in pediatric endocrinology, a 2-year course. And many of the people who are here actually are part of that course. They are coming 4 times in a 2-year period to gain experience, clinical, as well as learning in that perspective. We have developed the MedEClasses endocrinology app, which I was talking about. It's the most downloaded pediatric endocrinology app with over 5,000 installs, a lot of publications coming onto it. We are working in terms of developing connected clinics, which will help out people develop personalized care in terms of specific disorders. So we have developed tools to guide evaluation for growth failure, which have been validated. There are tools for management of diabetic ketoacidosis, which have been shown to reduce the complications of DKA. We have developed a bone age application, which provides within 2 minutes a reliable and valid way to assess bone age, which has already been published. A lot of other interpreters are there, which are being published, include our obesity interpreter, our puberty interpreter, as well as thyroid interpreter. So these interpreters are going to make life very easy. You have to enter the values and you will get the right outcome. And they have been validated in a large number of patients in that perspective. We also developed a DSD interpreter. And the next step, which Vibha was talking about, was the bone age assisted interpretation of growth, in which all the pediatricians have to do is to enter some basic information with regards to the child in terms of their age, in terms of their birth weight and other parameters. And then you have to enter about their pubertal status. And then you can either have a manual entry of bone age, or you can have a data which you have to select the sites and get the right data in terms of bone age. Now, this bone age assisted interpretation of growth is a tool we have been using and validating for the last 1 year in our center. And this has been found to be perfect in terms of not only plotting the data, but also getting a lot of interpretation and whether our puberty and growth is going normal or not. So this is going to be probably a way in which we can really screen a large number of normal children, as well as patients who are coming to different pediatricians in terms of school, as well as clinic, to get the right guidance in terms of evaluation and management from that regards. So we have got different courses. We have on-site course. So we have had 7 on-site courses till now. And yesterday we had a big number of around 48 participants from across the world actually, and over 300 patients who had come from different parts of the country to specifically come and get exposed in this perspective. We have got multiple publications, and we are now coming up today with the 2nd edition of MedEClasses Basic Pediatric Endocrinology.
Actually, thyroid nodule is a specific growth within the thyroid gland, which is ultrasonographically different from the thyroid parenchyma. So, starting with the case, we had this 14-year-old girl presented with the thyroid swelling. The swelling was localized to the right lobe, and she has mild features of thyrotoxicosis. The FT4 was high and the TSH was 0.01. So, in this case, USG and FNAC was planned. So, here the question comes, should we really go for the USG and FNAC in this case, or there is another choice of investigation? So, when the patient presented with the thyrotoxicosis and TSH is suppressed, definitely the choice of investigation here is the technetium 99 per thyroid scan, and we should go for the scan. Now, coming to what is the choice of investigation in different scenario based on the TSH level. So, the ETA guidelines 2023 clearly says that if the patient comes to you with a thyroid swelling, always take the detailed history regarding the family history, exposure of any radiation, carefully uh, examine the thyroid nodule, what is the consistency, what is the size, and what is the mobility. And the first investigation should be done is the TSH, because the further investigations are planned according to the TSH. So if the TSH is suppressed, like in the previous case, we should go for the free T4, trap antibody, and definitely the scan. And if the scan we found there is a hot nodule and a cold nodule, if we get the cold nodule, then definitely, we should go for the USG for the stratification of the risk of malignancy. And on the basis of USG findings, then we go for the FNAC. If the TSH is normal, patient is euthyroid, then we can directly go for the USG and then for FNAC. But in the cases where there is a thyroid swelling nodule, the TSH is elevated. So we should go for here this free T4 level anti-TPO antibody, and again for the USG. So directly not going to the USG, we should go for the TSH level first. And again, the family history of medullary thyroid cancer is very important. And for this, the calcitonin level should be done in the patients of thyroid nodule. Now moving towards how should we evaluate further in the case of thyroid swelling. So we have this 13-year-old boy who presented with thyroid swelling localized to the right lobe. He was asymptomatic. He was euthyroid. And what does the USG shows? It shows irregular margins and the calcification, as you can see in the picture. So as these are the suspicious signs which point towards the malignancy, without doing any further investigation, he was directly planned for the lobectomy. So the question here is USG findings enough to make the final diagnosis? Definitely no. The ETA guidelines 2022 clearly says that USG alone cannot definitely distinguish the benign thyroid nodule from the thyroid cancer. And in suspected nodules, FNA is recommended. And when doing the USG, we should evaluate all the lymph nodes, cervical lymph nodes, to check the metastasis. And we should cover the whole thyroid band along with the cervical chains, 3 to 4, second, third, fourth, and with the fifth level of cervical lymph nodes. Now, we know we just write the thyroid USG and we send the patient, but we should clearly write in the prescription that what we want the radiology to see in the thyroid, this USG. So the USG thyroid should contains and should explain these particular points, because these are very helpful in making the diagnosis of or in ruling out the this benign from the malignant lesions. And the report should clearly explain what is the echogenicity size of the thyroid lobe. How is the nodule? What is the size? What is the echogenicity? What is the composition? And is there any suspicious or non-suspicious signs present? Or is there an extrathyroidal extension? And now coming to the question, which discrete lesion to be described? Any lesion which is more than 1 centimeter should be described. And if we have more than 3 nodules, then what to do? How many lesions should be described? The guidelines says that the largest one, and those with the suspicious signs, if the number is more than 3, and if the pathological lymph nodes is present, definitely the characteristics of the lymph node should be mentioned in the USG. Now, coming to what are the suspicious USG findings that point towards the malignancy? There are irregular margins, microcalcification, and the hypoechogenicity. Coming to the ultrasound characteristics, I talked about the pointers towards the malignancy, that are the irregular margins, calcification, taller than wider, which is mostly applicable for the adult patient, hypoechoic, and the solid part. The study showed that the sensitivity of each and every USG characteristics have different sensitivity and specificity. And we can not just go with the calcification or the irregular margins. When we combine all these USG characteristics, our sensitivity and specificity is increased from 28.1 to 93.2 in the sensitivity. And while combining all these USG characteristics, we can increase the specificity from 41.4 to the 100%. So always combine these USG characteristics while making a diagnosis. And the same is done by the American College of Radiology, which is ACR TIRE scoring. It combines all the USG characteristics composition, echogenicity, shape, margin, and the echogenic foci. And by each of them characteristics is given a point. And when combining all these points, it has been characterized into the various categories. And then this judgment or the guidance for the FNAC is done. But the studies have showed that the ACR tire scoring is better for the adults in diagnosing the benign from the malignant. There is a Europeans has also prepared the thyroid scoring, but they have not involved extrathyroid extension and the composition of nodule in this. What about the pediatric nodule? Can we use the thyroid scoring in the pediatric thyroid nodules? The study showed that it is not very good for the pediatric thyroid nodules. And this study was done by the American College of Radiology, in which 340 patients younger than 19 years with 404 thyroid nodules were studied, which has a high percentage of malignant nodules, and among which 17 of 77 nodules would not be recommended for fine needle aspiration. It means they were missed and they were suspicious of malignancy, but they were not, the FNAC was not recommended in these cases. And what another, they have found that it reduced the biopsy rate of benign nodules in only 31% cases. So definitely those show that the ACR thyroid scoring which we are using now is not good for the pediatric patients. Some modification should be done in these patients in the thyroid scoring, like for the TR1 and the TR2. Regardless of the ultrasound characteristics, all the nodules larger than 4 centimeters should undergo FNA. And the other modification that they advise is that in the TR stage 3, the perform FNA in all the nodules which is 1.5 centimeter or larger. And in the TR4 risk level, we can see they have said to perform FNA in nodules 1 centimeter or larger, and in the follow-up nodules in which are 0.5 centimeter or the larger. What they found in some cases which were proven cases of malignancy, but the USG has shown the this benign features. Like in the first picture, you can see there is a cystic, semicystic consistency, and the margins are smooth. In the second case, we can see that there is there is a regular margin with the solid cystic area. These were proven cases of malignancy, but according to the thyroid scoring, they were considered as benign. So now coming to the, after doing the thyroid, USG thyroid, then what should we do next? How should we proceed further? So again, this 15-year-old boy presented with a thyroid swelling, and it was localized to left lobe. He was asymptomatic, euthyroid, and the USG NAC showed regular margins, cystic, hypoechoic, and size was 0.5 centimeter. So FNAC was planned in this case. Now the question comes here, whether this patient require FNAC, what are the indications of FNAC? So this is the 88 nodule sonography patterns which show the risk of malignancy, and they have clearly showed that on the basis of USG characteristics, we go for the FNAC. Like in the high suspicion of cases which have microcalcifications, irregular margins, hypoechoic, and this taller than wider. The size which is more than 1 centimeter, definitely we should go for FNAC here. While at the low suspicion and the very low suspicion, the size is more than 1.5 centimeter, we should go for FNAC. But in the cases of benign nodules, FNAC is not required at all. And in our previous case, the FNAC was not required as the case, it was a benign nodule. But all the lesions, irrespective of the size, if there is an extrathyroidal extension, compression, abnormal lymph node, we should always go for the FNAC. Based on the FNAC, Bethesda system has been formed for reporting the thyroid cytology, and they have characterized the lesions in 6 classes: non-diagnostic, benign, ATP of undetermined significance, follicular neoplasm, suspicious for malignancy, and malignant. Here I want to highlight that there is a little bit difference in the nomenclature from the 2017 guideline and in the 2023 guideline. They have just replaced, they have just skipped the lesion initially we used to say there is a atypical lesion of undetermined significance or the follicular lesions, but now they use the term of ATP of undetermined significance, and only the follicular neoplasm term is used in place of follicular neoplasm or suspicious for a follicular neoplasm. The usual management is same in both the guidelines, like repeat FNA in the non-diagnostic lesions. In the benign, we have to follow up the case. AUS, as it is a category of in dilemma whether to go for the molecular testing or diagnostic lobectomy. In the follicular neoplasm, suspicious for malignancy and malignant lesion, definitely we should go for molecular testing first, then either lobectomy or the total thyroidectomy. So coming to the case, we have the same case who has this USG characteristics of benign lesions and size is 1.5 centimeter. And FNC showed the benign nodule. Then what to do next? Either we should follow up the case or we should go for the molecular testing or anything else. So here, the management for the thyroid nodule, especially in the benign cases, the ETA guideline says the FNC is repeated in the cases of first if there is a non-diagnostic sample, and if the Bethesda class 3, that is the AUS type, and if there is discrepancy between the US ultrasound risk score and the cytological findings. In the Bethesda class 2, that was the previous case, if the lesion is benign on the FNAC, then what to do? Follow up the USG in 6 to 12 months, and FNAC is only required if the suspicion signs develop. And for the stable nodules which do not show any suspicion signs, the USG should be done in 12 to 24 months till 5 years. And if during the meantime the size increases by 20%, that is more than 2 mm, and the volume increases by 50%, definitely we should go for the FNAC. So coming to the similar case, now we found atypical or undetermined significance in the FNAC. Then what should we do? Because this is a category where we are always in dilemma what to do. So the molecular testing has come up. Guidelines recommends that every lesion of category 3 should go for the molecular testing because it would help in it is important for prognostic information and it would guide in the extent of surgery. So there are several this thyroid genetic testing like Afirma, GC, Thyrosex V3, Thyronext, and the thyroid prints, and their type of test is different in all these. So based on the molecular testing, how do we go further? This is important. If we have this Bethesda 3 or 4 cytology, and we have done this molecular testing, and in the molecular testing we found there is no mutation, then definitely no intervention is required. We will observe the patient. But if there is a RAS like this is positive for RAS like mutation, then definitely lobectomy is done. On the other hand, if the patient is positive for BRAF like mutation, then total thyroidectomy or lobectomy is done. And if the patient is positive for multiple driver mutation, then definitely it is a high risk cancer and total